to the channel, guys. It's Dr. Mivi Singh, and today we're going to be looking at two different things in the real ED. The first one is triage, and the second thing is something called a pneumothorax, sometimes known as a lung collapse, sometimes known as air trapping. Many people think that they can take an accurate history or do the correct type of triage. Triage is one of the very first things that is done when a patient comes into the emergency department, which is where a nurse will sit down and go through, why have you come in? So for example, chest pain. Now with chest pain, there can be a whole different host of different conditions or symptoms. So somebody could be having chest pain from having gone to the gym, having muscular strain. Someone could be having it because they've got shingles, which is a viral infection which happens on the skin. Someone could be having an injury like by having a cut. It could be a chest infection. It could be a clot in the lungs known as a pulmonary embolism. It could be a heart attack. It could be a lung collapse, which is the pneumothorax, which we're going to come on to. It could be the aorta having burst. So there's a whole host of different features and even more. That's just a few that I've covered. But essentially, by asking the patient, what happened, where were you, what were you doing, have you had this before, asking about certain risk factors, these questions can be asked and the answer obtained literally within under a minute. And that is how you get an effective triage. That then means that you can categorize and risk stratify a patient properly for the rest of their journey in the department. And it's the same thing that you should do as doctors as well, which is take an accurate history. Most people will follow a system that you will learn in medical school, but nobody then continues to do that when they're practically working. Don't know why, but you need to. You need to be drilled into your head that that's what you need to be able to do, because it will mean you get the accurate information. And a lot of the time it's because patients will tend to wind away from it or not give the accurate information, and you have to pull them back. So that's a skill. It's a communication skill and technique that you have to learn. Sometimes it may seem embarrassing to actually ask the question again, or it may not be deemed pleasant to ask the same question twice when a patient believes they've already answered it. But it's important to say to the patient, look, I do need to go into the details, I do need to ask the specifics, because that is how it helps me make a diagnosis. The other thing is, sometimes people think by being super quick and missing the actual questions and not bothering to get the answers means that they're very efficient, that they're very quick. But in actual fact, it just means that everything's going to become slower, less accurate, and is going to cause further delays down the line. So taking an extra minute to do things properly in the beginning can save sometimes even an hour afterwards. Next thing, let's get on to the pneumothorax. That is where the lung actually collapses and there's air in between the lung and the chest wall, just like in this diagram over here. So a pneumothorax can be small, large, or something that can become extremely dangerous, known as a tension pneumothorax. That's where so much pressure is exerted through the collapse of the lung that the heart actually starts to get squished and it can't pump. That is life-threatening. So what do we do with that, and what did we do with the patient earlier on in the shift is lifted their hand up above their head, and in this area here, which is called a safe triangle, that's where we inserted a tube. So we give local anesthetic and we put a needle to go through the chest wall into the lungs and put a guide wire in. This is known as the Seldinger technique. And then through inserting that wire, we use a blade to make a slightly larger incision to put a trocar. A trocar essentially allows it to increase the space and therefore allow the actual tube to go through the chest wall into the space where the lung is. And that way we can then extract the air, and it goes into a tubing that goes underwater. This is known as an underwater seal that prevents air coming back. It is quite cool. And so this patient who went from not being able to breathe, extremely short of breath, and was pretty much on death's door, we managed to get them back to pretty much full health, apart from having a tube sticking out of their chest going into this underwater drain, within about 5 minutes, preventing them from potentially having a cardiac arrest. A cardiac arrest is where the heart would stop working. This procedure was an emergency and it saved the patient's life, so it was great. Remember to like, share and subscribe, guys. Let's help grow this channel, grow this community, increase your knowledge, increase your problem solving skills and abilities, to become better in your profession. These videos are going to be pure raw type of videos because there is no time to sit down and edit in such a flashy way. So I think you'll appreciate this. In the world and advent of artificial intelligence and everything looking the way it looks, I think I'm going to stick with the raw type of technique and the raw type of filming, because I think a lot of people are going to like it, and I think a lot of people are going to want to go back to that. So I'm going to stick with this. Catch you all next time.